Hello. Yesterday, I saw a middle-aged lady with an arm bone fracture and weak bones who came to me from another part of the country 2 weeks after the initial treatment. Shoulder replacements are less commonly done, but when done by right hands, are as successful as knee and hip replacements. The expertise and facilities for shoulder resurfacing and replacements are not widely available. This is more the case when biologic innovations are integrated into the procedure. Biologic solutions have increased the life of a shoulder replacement by removing the weak link. Therefore, this is the importance of this lecture. The points are that shoulder resurfacing expertise is not widely available, and a new innovation with biologics and stem cells has increased the life of a shoulder replacement, and therefore you should pay more keen attention to this, particularly if you're elderly or if you're suffering from shoulder pain or relatives have got shoulder pain, osteoarthritis, rheumatoid arthritis, etc. So now let's understand the anatomy of the shoulder joint. The shoulder joint is made up of three bones. Your arm bone, this is the arm bone. I'm showing you the left humerus. This is known as the arm bone or the humerus. Your shoulder blade or the scapula, and the collar bone, the clavicle. The junction of these three form two joints here. There is a socket at the outer end of the scapula or shoulder bone, and there is a shallow socket, and there is a ball over here. Here, you can see the ball here at the upper end of the arm bone. This ball is known as the head of the humerus or the ball. So the ball and socket, they form a ball and primary ball and socket joint. Above this, there is the acromioclavicular joint here, where the clavicle or the outer end of the collarbone joins with the acromion, which is a projection from the back of the scapula coming front, and that is known as the acromioclavicular joint. Sometimes this joint can also be painful. The joint is lined by a shiny articular cartilage, which is smooth. So you can imagine that this is a small pebble, ceramic pebble. You see how smooth it is. And this is the lining at the outer, at the bones. The remaining part of the joint, which is not lined by synovial, by articular cartilage or joint cartilage, is lined with a membrane called as the synovium. And the synovium occupies the rest of the joint space in the shoulder joint. The shoulder joint is stabilized by muscles and tendons. You have the huge arm muscle here known as the deltoid, which arises from the collarbone and the acromion and the side of the acromion, which is the deltoid muscle. It surrounds it. And then from the back, you have the other muscles, powerful muscles, which help to elevate the arm. And then in the front, you have muscles arising from the front of the shoulder blade and attaching here. All these muscles move the joint, but particularly there are a group of four muscles known as the rotator cuff, which are located from front, above, and back. These muscles and tendons stabilize the joint and provide stability and support. All these structures allow the shoulder joint to rotate through a greater range of movement than any other range in the body. The importance of this is that the function of the shoulder, main function of the shoulder joint is to position the hand outwards in space, to reach out to pick up an object from the table, to eat, or to get behind your hair to comb it, or for personal hygiene behind, or reach out to the side, and so the shoulder joint, as you can see, has got a wide range of movements, and it is an unconstrained joint. This laxity or the freedom of movement is partly responsible for the incidence of dislocations, particularly a kind of dislocation to the front. And when the joint dislocates, it does not, the structures, the tendons and ligaments don't heal, and it can lead to recurrent dislocations. And recurrent dislocations, if untreated, can lead to post-traumatic or arthritis in the long term. So now we're talking about shoulder replacement. What are the conditions which lead to patients to consider a shoulder replacement? There are about 6 or 7 conditions. The first one, like any other joint, is osteoarthritis. Osteoarthritis is an age-related condition due to wear and tear. It occurs in people over 50 years of age, but may occur in younger people with weak cartilage. The cartilage lining that cushions the bones of the shoulder softens and wears away. The bones rub against each other, and over time, the shoulder joint becomes stiff and painful. In the early stages, there may not be restriction of movements, but the patient will experience pain during certain arc of the movement. But later on, the joint becomes stiff due to overgrowth of bone known as bone spurs around the joint. Rheumatoid arthritis. Again, this is a next common type of affliction leading to shoulder replacement. It is an autoimmune disease in which the synovial membrane, as I talked about, the synovial membrane which lines the entire shoulder joint, that becomes inflamed due to deposition of certain antibodies and inflamed and thickened. Over a period, this long-standing inflammation or chronic inflammation can damage the cartilage and lead to loss of movement and pain. Usually, both the shoulder joints are affected, and as are other joints also, requiring bilateral shoulder replacements and bilateral knee hip replacements, other joint replacements also. The next, third common one is post-traumatic arthritis. This follows severe fractures of the head of the humerus or the ligaments, the rotator tendons, or as I said, the ligaments which lead to dislocation. So these fractures, joint injury, tendon injuries, ligament injuries, when left untreated, can lead to shoulder arthritis. The next condition which causes pain and may require shoulder replacement is avascular necrosis or osteonecrosis. In avascular necrosis, the blood supply usually goes from outward to inward. The blood supply, when it passes through the bone, it may be cut off, it may be choked off, and the cells inside the bone over here in the head of the humerus, they die. When they die, the bone collapses. But ultimately, what happens is the support to the joint or the articular cartilage is lost, and the shoulder becomes arthritic. The causes of avascular necrosis are steroid intake for eye ointment, for asthma, or any skin condition. All these are risk factors for avascular necrosis. Number 5 are severe fractures of the shoulder joint. We have fractures known as 3 or 4-part fractures, which are very complicated. Sometimes the bone becomes too shattered, and then it becomes very difficult for the surgeon, however skilled he may be, and particularly after a period of time when there is a delay between the injury and the treatment, or due to weak bones, it is very difficult for the surgeon to put the bones back in place like Humpty Dumpty and assemble them together to get a stable fixation. Under such conditions, because of the severe fracture, the blood supply also to the shoulder, to the arm bone, can get interrupted and result in avascular necrosis. So you have a double whammy effect. One is the fracture itself, and then the blood supply, and both in collusion may require a shoulder replacement. So the surgeon may recommend a shoulder replacement in this condition. Older patients with osteoporosis or weak bones are most at risk for severe shoulder fractures. And it is in these patients who are very much reliant on the upper limb. Sometimes they are homebound due to arthritis or weakness or back pain, and they depend more on the arm. And they even use the arm to even climb out of the chair. So when these patients suffer a fracture, then they can't use the arm to stabilize them. They can't use the arm to eat. So, and they require assistance. So severe fractures may require a shoulder replacement. Rotator cuff tear arthropathy. I talked about the rotator cuff tendons. When there is a large tear and there's a patient with a large tear, which he may and which is long-standing, not healed well, not repaired, it's too big to repair. The shoulder is always unstable. The long-standing rotator cuff tears may lead to a condition known as cuff tear arthropathy and may require shoulder replacement. The other condition is we mentioned that shoulder replacement surgeons are not widely available. So failed previous shoulder replacements done elsewhere, may lead to pain and need because of implant loosening or infection or dislocation. And when this occurs, a second replacement surgery called revision surgery may be necessary. The weak component in the shoulder joint is this plastic part. This is the shoulder blade. There's a bony socket here, and you have a plastic socket which is fitted into place here. This is the weak component. It often wears or it wears off very soon because it's very thin, and or it may get dislocated. And this is the weak component, and this may require shoulder revision. I have eliminated the weak link in the shoulder replacement, as you will see, by a biological resurfacing, which was used. And I'm proud to announce that I have developed the resurfacing in which the plastic component of this socket is done away with, and the glenoid is resurfaced with biologics. The first patient who underwent this was a 59-year-old American, and at the latest communication, the day before yesterday, he is doing exceedingly well after nearly 3 years. He should be watching this program. Hi, Mr. Rick Perrin. If you're watching, just drop a comment below. This is to Mr. Rick Perrin. So, when is a shoulder replacement required? If the patient is suffering from excruciating pain and stiffness, has tried out all non-operative measures and injections. We'll talk about injections later. Sometimes injections like biologics or steroid injections can be given. Too many steroid injections are bad, 1 or 2 is okay. Biological injections, when there is an early stage of osteoarthritis, we can try platelet-rich plasma or signaling cells from fat and from bone marrow. When these have not worked, they work for a short time, but after a while, when their effect has gone away, the X-ray shows bone-on-bone contact. There are bony spurs obstructing the range of movement. The range of movement is very much restricted. The patient can't lift the arm above 90 degrees, which is very debilitating. Then shoulder replacement is required. What are the patients ask me? What are the type? This is the information of the patient. What are the types of shoulder replacement and when are they done? There are about 4 types of shoulder replacement. Let me enumerate. The first one, the simplest one, is a resurfacing, shoulder resurfacing or surface replacement. The next one is a total shoulder replacement. The third one is a stemmed hemiarthroplasty. Arthroplasty means part of the joint is replaced by a prosthesis. Hemi means half. So one half of the shoulder joint, which is the broken off, usually it's at the upper end of the arm bone, which is the ball, that is replaced. So a replacement of that alone is known as a stemmed hemiarthroplasty. And the fourth one, which is the big daddy or the mother or the final operation in the shoulder surgeon's armamentarium is a reverse shoulder replacement. Now we'll talk briefly about each of these conditions and the indications for each of them. Shoulder resurfacing is done when there is cartilage loss. Obviously, there is cartilage loss has led to arthritis involving the ball and socket joint without significant bone loss. The rotator cuff tendons, they are intact, and there is a normal anatomy. In this procedure, the head of the humerus is not cut off like in the femur. This is the head of the humerus. Usually for shoulder replacement, it is cut off here and the metal prosthesis is put here with a ball. In shoulder resurfacing, this stays. This ball, you can see here, it stays. The surgeon will expose the shoulder joint through a minimally invasive approach. He will scrape the worn out surface or worn out cartilage with instruments and then place a metal cap, uncemented metal cap with a small peg at the top of the ball. This cap is hammered into place and it is not cemented, it's an uncemented shoulder replacement. The fixation is with bone and the tight fit achieved. Similarly, the socket over here, this can be scraped and it can be fitted with a plastic component. So then this becomes a total shoulder resurfacing. We talked about biologic resurfacing. Here, the socket has to be replaced. The socket need not be replaced when the cartilage on the inner side of the joint of the socket is intact. The glenoid cavity has got poor bone quality and the rotator cuff tendons are torn. In case it is worn and it needs to be resurfaced, then I have developed a biologic resurfacing with medicinal signaling cells. Medicinal signaling cells means these cells have got a potency to stimulate or trigger other reparative cells within a joint to form cartilage. These cells can be obtained from fat, which I am right now doing, or from bone marrow, or if one can, if facilities are there, from amniotic membrane or umbilical cord cells. This biologic resurfacing is particularly useful for younger patients, say any person in their 50s who need shoulder resurfacing. Mind you, this biologic resurfacing is only, I have used it so far only to resurface the socket side. Maybe over time we can use it to resurface the ball also, and then that would be a total biologic resurfacing. So shoulder resurfacing with biologics or with a plastic is a bone preserving option because the bone is not cut. So this option is helpful. It may be an option for you if the glenoid still has an intact cartilage surface. There has been no fresh bone loss in the head of the humerus, and there is a desire to preserve humeral bone. For very young patients who need, and they're very active and they need a resurfacing to get rid of pain, resurfacing hemiarthroplasty avoids the risk of component wear and loosening that we talked about, which may occur with conventional total shoulder replacement in patient population due to its more conservative nature. Resurfacing hemiarthroplasty may be, or resurfacing may be easy to convert to a total shoulder replacement because we have not lost any bone. It is just sufficient to cut the bone at the neck of the arm, at the neck of the at the top here, the neck here, and put a stemmed prosthesis if required at a later date. The innovation of a biologic component introduced by me should hopefully prolong the life of a resurfacing and reduce or eliminate the need for conversion to a total shoulder replacement and further revision surgery. Now we'll talk about total shoulder replacement. This is the commonly performed operation anywhere in the world. Shoulder resurfacing, which I talked about, is very uncommonly performed. I have been performing it from 2008. Most surgeons for arthritis, they will recommend a total shoulder replacement. This is a more bone, it is not bone preserving, but bone losing operation. In total shoulder replacement, the head of the humerus is cut off. Here, the head is chopped off, and the metal prosthesis is inserted into the top of the arm bone, like that. And that one over that, we have a metal cap which will be fitted snugly onto the stem. This stem can be cemented or uncemented. Then on the socket side, a plastic part is cemented into the top of the, usually the plastic part is not cemented, it is fixed with a tight fit or screws, and a plastic part is used over here. This is a total shoulder replacement. In the total shoulder replacement, the positions of the ball and socket are maintained. Again, in a total shoulder replacement, the socket can be lined with the biological option, which I've used before, and therefore it becomes a metal shoulder replacement on one side and a biologic shoulder resurfacing on the other. So again, since the weak link of the shoulder replacement has been eliminated, a total shoulder replacement with a biologic and metal component may prolong the life of a total shoulder replacement. The third type of shoulder replacement is known as stemmed hemiarthroplasty. It is done for severe fractures of the upper end of the arm bone, type 3 or type 4 fractures. The socket is usually intact, and a stemmed prosthesis is inserted into the upper end of the arm bone, and movement can be restored. Other indications for a stemmed hemiarthroplasty include shoulders with very weak bone in the glenoid, severely torn tendons, and arthritis. The big daddy of shoulder replacements is known as a reverse shoulder replacement. In this, the head of the humerus is cut off at the neck of the humerus, as in a total shoulder replacement. But instead of the ball being fitted into the humerus, a socket is fitted into the humerus. The ball is reversed in direction and fitted onto the socket. The ball comes here. Here at the arm bone, you have the socket. So since the positions of the socket and the ball are reversed, it is known as a reverse shoulder replacement. Reverse total shoulder replacement is used for people who have completely torn rotator cuff with severe arm weaknesses. They have developed a condition known as rotator cuff tear or cuff tear arthropathy. Then other patients who may require a reverse shoulder replacement are patients with very severe fractures and damage to the rotator cuff. And the final indication or need for a reverse shoulder replacement is when they've had a previous shoulder replacement elsewhere that has failed. For these patients, a conventional shoulder replacement or a revision shoulder replacement can leave them with a lot of pain. They may be unable to lift the arm beyond a 90-degree angle, which is very severely debilitating. As I said, you cannot reach out to the table to pick up your food and to eat, or reach back also. So a reverse shoulder replacement is required. Now, after having heard all this, you may say, Doctor, this surgery is very technical. And so how can we decide what is the right operation for us? Yes, shoulder replacement surgery is highly technical. It should be performed by a surgical team with experience in these procedures. Meticulous investigations and pre-operative planning are necessary to determine the amount of bone loss, assess the integrity of the rotator cuff tendons with MRI, and then plan which biologic is to be used, whether PRP or PRP needs to be injected into the rotator cuff tendons, or the socket needs to be resurfaced with the stem cell paste. etc., etc. So it's very complicated for the shoulder replacement. For your information, I performed the first shoulder resurfacing in Chennai and probably in India in 2008. I also performed the first shoulder resurfacing with a biologic socket for the first time in the world in January 2017. The patient was a 59-year-old American male. He is doing exceedingly well after more than 2.5 years. I have also performed total shoulder replacement and reverse shoulder replacements. To see these patient testimonials, please visit my website, shoulderindia.com. Then you will see a lot of shoulder operations, patient testimonials. Then can I request you also to subscribe to my YouTube channel, Madras Joint Replacement Center, which I am showing you here, or MJRC. If this is the right orientation for you, Madras Joint Replacement Center, or MJRC for short. My YouTube link, if you type it, is youtube.com/user/AKVenkat. This is the YouTube link on which you are able to, while you are watching now, and you'll be able to see all these shoulder procedures and testimonials. How is the surgery done? It is done under general anesthesia and a nerve block for post-operative pain relief. The procedure takes about 2 hours. After the surgery is over, you'll be observed in the recovery room for a few hours. When you have recovered fully from the anesthesia, you will be shifted to your room. How long does the patient have to stay in hospital for a shoulder replacement? Only 1 day stay is required for management of acute pain. What is the post-operative protocol after shoulder replacement? The arm is rested in a sling at 90 degrees for a week. The patient can remove the arm from the sling and move the arm, extend or straighten his elbow, and then move the shoulder and elbow 2 or 3 times a day. The sling can be discarded after a week or two, and then the patient can move the arm freely. What are the complications of surgery? Like in any other joint replacement, the complications are infection, loosening. We have eliminated loosening by addition of the plastic, removal of the plastic component and substitution with a biologic component. So loosening less likely to occur. Prosthetic problems, the stem part can become loose, and nerve injury. So I hope this was useful information for those patients considering a shoulder replacement. Please tune in to my YouTube channel, Madras Joint Replacement Center. Madras Joint Replacement Center, MJRC, and subscribe. Hit the subscribe button to see shoulder replacement operations, patient testimonials, and notifications about more live sessions. Please visit my website dedicated to shoulder problems. I have a website dedicated to shoulder problems. Not only can you see operations, but you can also know about other shoulder conditions like dislocations, slap tears, rotator cuff tears, all these. So you can see all these links, link to my social media in the description below. I'll be dropping it in the social media in the links below. So thanks for watching and have a great day. Thank you.